but let's just go through for accuracy in the first instance. So on page 1, page 2, page 3, and page 4, page 5, page 6, and page 7, and then page 8. And I think somewhere I had a page 9, but it was at the very end. So can we agree that those are an accurate record?
Yes.
Fabulous, thank you all. And we've got the action log, where with thanks to Caroline and Syra, we have actions closed in the main. There's one action which I know, Andrea, came up through your meeting this week and which was mentioned in the in the minutes, but I don't think had an action, which is the issue about where we've got governor vacancies, particularly around appointed governors. So just to say, Caroline and I, well, Caroline has helped me. We have written letters now twice to relevant bodies, which include councils, other trusts, and the police. And in some instances, when I've been able to nab people in person, I've received assurances that people are being identified and will join the Board of Governors. But unfortunately, it's not turned into real bodies or real people yet. So what we are trying to do now is to come up with a plan of action to resend some form of communication, which I think shall go from Steve and I to the relevant bodies. It's a good opportunity for Steve to introduce himself to partners such as the police anyway. We'll have another go. And the thing we can't do is actually make people put themselves forward. And I do respect that every single bit of public service at the moment is very stretched and it may well be hard to find people, but we will keep trying. The other plank of that is around where we've got carer governor vacancies. Caroline and I are following up on those because Keith very kindly offered to help on that and did some work with Anna Tuke around trying to encourage some people to put themselves forward to be observers, to discover what it was like being a governor, with the ideally putting themselves forward to be elected next year. But so far, no one's been brave enough to come forward as an observer. So we're going to try and do a bit more nurturing there under Anna's team. So I didn't want you to think that that element had been forgotten. But hopefully, if everybody's content, that takes us through the minutes of the last meeting, matters arising from it, and the actions that were outstanding. Is that okay with all? Perfect, thank you. All right, we'll go to my report, which I will, if you'll excuse me, I will take it as read. I'm not going to repeat that element of it. I was very grateful to all of you who were able to support completing the COG annual effectiveness review. And again, Andrea very helpfully fed back some comments of practicality, if you like, around some of the questions, the complexity of them, the timing of them, the timing of the actual survey itself, and the fact that it would have landed, although it ran over essentially a 2-month period, it landed at the beginning of the summer and ended, beginning of August and ended in September. It elicited, as it had done, I gather, in 2021, almost exactly the same percentage of responses, which was about 50%. And whilst 50% is reasonable, we do like to be ambitious. We'd like to get more. So we're going to think hard about doing this again and look at the questions that it will be, where we'll genuinely get some value out of asking those questions and being able to answer them well through your responses. And also there are a number of other things that come out of the responses you've given, which certainly have given me and others pause for thought around what we could do better, what we might want to do differently, such that we are an organisation that people will look to say, that the Council of Governors is really working well here, and that people feel well engaged, well supported, and that there is value going in both directions. And whilst the responses give a sense that a great deal of the time it feels like that's the case, we know we've got more to do. And that's something that Steve and I have already given some thought to, and some of which I have passed on to Andrea. And I'll invite Andrea to talk about her thoughts in just a moment. So we want to do more work with you. We want to make some changes that will feel positive, but we want to do these together, not to you. And with that in mind, there's a couple of things that I'm going to suggest. The first is, and this is particularly, but not exclusively, because we've got new governors or newish governors who we want to make feel part of a community of governors who are valued. And Karen, who unfortunately can't be here this evening, in that spirit is going to be reaching out to the whole governor community and inviting small groups to get together to actually talk with her about what drew you to being a governor, what your expectations were, what you'd like to do more of, what you might like to see less of, what could work better for you. So that actually we're beginning to build that sense of a governor community that feels connected and engaged. So you will be getting a note from Karen asking if you could give some time to that. And I would be hugely appreciative of it. I think it's quite important that I, as the chair, let Karen do this semi-independently, because there may be things about the way I chair that you're not, you think Eileen could be better. So this just gives you somebody else to talk with. And what I'd really like to do out of that is to get a sense of collective determination that we want to be an exemplar of how a council of governors can work really well in support of a hugely important NHS organisation being successful. If I link then the effectiveness review to the fact that we are now really embarked upon a well-led review with the Care Quality Commission. The CQC are with us already. I ran a meeting this afternoon that was observed by the CQC, and that's absolutely fine, and as it should be. We want them to be able to give us really honest feedback about how we can improve our governance and our leadership of the trust. So we're not going into this with any pretense that we're going to say that we are perfect. There are many people on this call who've been along this journey with me in particular over the last 18 months. It's 2 years since I joined the board of CPFT. And we've been through many changes together and some challenges. And we are looking now with the appointment of a new chief executive and with some feedback that we'll get from the Care Quality Commission to really make sure that we're putting CPFT on its path to being what it consistently needs to be, the very best provider of community physical health and mental health services to those who need them in this growing area of ours, where we've had been a good provider. We are very often a good provider today, but we want to be an outstanding provider. And that because that's what our staff and the people we serve deserve. So you as governors have asked how you might be involved in that. And the honest answer is at the moment we don't know, because CQC, as I understand it, have done different things with governors in different places. We know that they will want to talk to one or two of you. They may want to talk to a group of you. We don't know when that will be. But we have signalled that in order to make sure that they can speak to the lead governor, deputy lead governor, that they might want to think before they come to us formally in February, that those conversations happen within times where people are available. So those messages are being relayed to the CQC, but it will be for them to decide what sort of a model they want to work with. And as soon as we know what that is, we will share with you. But we can't prescribe what it should be, and we can't give them dates because it just doesn't work like that. But that's a process we want to go through together, and to be positive about why we're all here and where we've had challenges, how we faced them together, and how we can see a very purposeful and successful CPFT in clear view on a very regular basis. So that's, I hope, linking the feedback you've given to some work that we want to do, and we want to do it together, with how that then links to the work that the Care Quality Commission is doing. And all of that is underscored by a message of improvement, because that's what we will be living by, a commitment to improve over probably what will in all likelihood be the next 2 to 3 years. This is going to be work of some time to get us to a position where we can all say most of the things we wanted to do are in good shape, and we're taking all and every opportunity to be ambitious for our staff and the people we serve. At that point, I'm going to invite Andrea to come in to just see if there's anything you want to add, Andrea. We've had brief discussion, haven't we, about some of the ideas that Steve and I have put forward, just to outline how we plan to work together.
Thank you very much, Eileen. Yes, if I might, I'd like to thank my fellow governors for what was a fantastic conversation at our COG pre-meeting, when we really had a bit of a heart-to-heart about what we thought of the evaluation review findings, and most importantly, what things we wanted to take forward. And it was a free-ranging discussion, and there were a few kind of key points coming out of that, which I'll just go over because obviously not everybody was there. I think governors were feeling frustrated, and most of us came to the conclusion that we couldn't say that we could put our hands on our hearts and say, yeah, we've got assurance about what the trust is doing. And that's because the way in which we're engaged doesn't really give us enough time to talk amongst ourselves. And a number of us who were on the nominations committee said how helpful it was last year when we actually had time together around the senior appointments, because we got to know each other. We dealt with some challenging stuff around appointments. We got to have a task, but a task where we felt we got to understand other people's views and knew each other a little bit more. So we would very much like something that's a bit more informal, but is about us working, not about us having a development session. And there was quite a lot of frustration about understanding board papers and subcommittee papers for those governors who observed subcommittees, particularly because of the vastness of the agendas and also the complexity. A number of governors were saying that, they're not NHS people, and trying to understand the data didn't give them any information. And when we come to our own COG pre-meet, it's also quite processy, because we're trying to go through the agenda and do a role of identifying issues on that agenda that has been fed by the subcommittee papers, obviously going through to board. So we're in this kind of process. And what we would really like to do is to build ideas and conversations about the key issues facing the trust, and to have the possibility to do more deep dive on issues without having all the data, because it isn't really something that governors can understand. And I was delighted when I gave you that feedback in the feedback from our meeting, because your response really kind of put the finger on something, which is, well, actually, those subcommittees are not for governors, really. Our attendance at them as observers is something that's historical from the previous chair. And now, with the new chief exec and the new chair working together, is an opportune time to do something that's different, that allows governors to have a role that governors actually can perform without trying to make us NHS executives, which we're never going to be, and we don't want to be, and don't have time to do anyway. But to be able to give something of value to the trust that adds to the governance, rather than is the end of a process where we've gone through something that most of us haven't really understood, and where we've asked questions we haven't necessarily had time to understand the answers. And so we're left feeling a little bit like we haven't done our jobs, but we don't quite know how to do our jobs in the context that we've got. And so it was wonderful when you and Steve came back so quickly with some suggestions, perhaps have a small group of us to work together to identify 3 perhaps bi-monthly meetings where governors actually could do those deep dives on issues and be able to have presentations and ask questions rather than to have all the data, because we know you've done all the data, so we don't need to see all the data. And I would very much be willing to help governors work with you to identify a way in which we can contribute going forwards. And I'm sure other governors would be delighted with that response. So thank you very much to you, Eileen, and to Steve for being so positive about it. I'd love us to be an exemplar site for governor involvement.
Well, I think we're all ambitious, so let's make that our ambition, shall we? So Andrea, if governors want to just volunteer to you, we don't want a huge group, but if we can get something fairly small and tight, then hopefully we can go into the new year with something slightly different worked up, which we may need to tweak, because nothing's ever perfect to start with, but let's sort of make that our mission, shall we? Be a good and positive way to go into 2025. Any questions at all before I hand over to Steve? Oh, all right, Steve, I'm going to be very pleased to. Sorry, I've got Mike and then Ed. Little flurry at the end.
Yeah. So, sorry, Andrea, Eileen, thank you very much. Just a personal comment, really. One of the things that stood out for me, you might not be surprised, was that visibility of NEDs was not good. And as a NED, I recognise that, and also I don't know the governors as well as I would like. So your ideas, Eileen and Andrea, sound very good to me. So an opportunity to work together on something to get to know each other a bit better. I do know some. I know Diana, and I've met some governors on service visits, and Helen comes to the Quality and Safety Committee. So I have made a start, but this is a very personal view. But in terms of how the governors and NEDs work together, I would. I'm sort of giving a thumbs up to what you're recommending, really. And the only other observation I'll make, there's quite a lot of new governors and quite a lot of new NEDs in the last 6 months. So, perhaps it's kind of inevitable that we are where we are, and we've spotted it and we're going to do something about it. So, yeah.
Yeah, no,
thanks.
Well said, Mike. Thank you. Ed, do come in.
Thank you. Just a quick one. Going back to your comment, Andrea, that governors felt that they didn't necessarily always have enough time to talk to each other as a group. I was just wondering how often do you meet as a group in person? Is that feasible, or is it all online? Do you think there could be a role for some kind of get together if that's not already on the schedule?
Shall I come back, Eileen? We don't ever meet in a private group in person. So there's the annual meeting, which is in person, but our meetings that are pre-meetings, which is where we meet without anybody else, are always online. And we have said we would like to meet once a year. And Sarah did very nicely come back and said, yes, she organises a social visit. We didn't mean that. We don't actually want to have a social visit. What we want to do some focused work on something, because we actually enjoy being focused on a task and getting to know each other through the task rather than just being friendly.
All right. Well, friendliness is always to be applauded in my book. But we have plenty of tasks, so let's find one to bring people together for. Claire, do you want to come in?
Yes, very briefly. Firstly, to echo what Andrea has said about the very useful conversation we had at the pre-COGS meeting, but also to comment that one of the things I think where we can help, and we do have some role to play, is the service visits. And I find those incredibly useful and helpful. But I'm not sure what happens to the reports on the service visits and how those are shared. I would just wonder about that. Don't necessarily need an answer now, but there's a role for governors to play there, and we are encouraged to go on service visits. So it'd be good to know about the reports. Thank you.
So Claire, let me assure you that all the reports go in. Well, so that all the executive and the NEDs see all the reports from every service visit that is done. And then Natalie, who works with Caroline, pulls together all the actions that are flagged in some of the reports. I mean, you will have seen one or two of mine, I think, when you and I have been on visits together, that there is an action log kept of things that have come up through service visits as well. So they are really helpfully used in terms of making sure that intelligence is shared and the actions are carried out.
I think I was wondering whether there's a possibility of sharing those amongst governors.
Okay, I think, well, I'll leave that for others to ponder, because obviously we need to be careful in terms of some service level information going outside of the trust. But, you know, I think certainly we can talk to themes that come through. Claire, we could certainly bring those to a COG meeting even and talk about the value of the intelligence that comes from the service visits. Is that okay?
That's fine. Thank you very much.
All right. Now I'm going to hand over to Steve. I give my voice a little rest. Steve.
Thanks, Eileen. And excuse me, colleagues, if I have a bit of a cough and splutter as I'm now starting to do. Thank you very much. This is my first Council of Governors meeting, actually, so it's a bit of an auspicious moment for me. So first of all, thank you for your support through the interview process and your many challenges that I'm sure you will have asked me about. And I'm sure I can also say thank you for the many challenges that you will be appropriately challenging me on in the future as well. Because one of the things that I think is incredibly important around foundation trusts was the ability to have members, the ability to appoint governors, and that conscience that you provide, that ability to ask those questions, sometimes without the excuse me, without the cloudiness of the NHS policies and procedures and the politics that we navigate through. That clarity of question that you can bring is something that I never really think has been capitalized enough, if I'm honest. It's a real ability to ask some of, they're not difficult questions, they're the real questions. And I think juggling those with how our communities respond to what we do is something that I think I'm very passionate about. So I'm getting close to 8 weeks in the organisation now, and the first couple of weeks I've spent really trying to go out to talk to people, and I make no, excuse me, apologies about talking to people in an unformatted, unstructured way. And I wanted to really go out and sit with teams, go and find teams, say hello, and in some cases do that reasonably anonymously, which has been fabulous. Some of you may not know this, but prior to me being interviewed by you good selves, at the point when I was doing my preparatory work, I did a mystery guest tour of a couple of our facilities and bumped into staff and asked them what was it like to work here. And the response I got from people was mixed. It was all positive, but it was mixed around, it's great, but the traffic's bad. It's great, but watch the A14, you know, those kind of conversations, which are the usual things. But what I got was when people said to me, you know, are you interested in working here? And I said, yes. What they wanted to do is they wanted to ask me what job I was looking for. And I think I was really keen to say, actually, just a member of the team. Because just being a member of the team gave me the opportunity to really engage with people at a completely different level. And some of the feedback that people gave me was priceless. I think 2 weeks in, I managed to meet quite a few teams. Probably now, I think I've met just shy of 600 of our workforce, which is not as many as I would like, but enough of a sort of percentage of our workforce to give me a real sense as to where the heartbeat of the organisation is and where it could be. And some of that, I think Eileen's already mentioned, actually, is incredibly positive. It's really clear that CPFT has been through quite a bit of turbulence over the last 18 months, 2 years. Some of that in the leadership space, some of that in the politics space, and some of that in the midst of changes around navigating the organisation through new governments and pandemics and all of those things that are distracting. But the one thing I will say throughout all of that is it was really clear to me that the culture of care was rock solid. And it was the bit around people wanting, in despite of those changes, in despite of that sometimes lack of clarity, and in despite of sometimes lack of decision making, was a real sense of it being safe and caring and responsive and effective at a clinical level. And that completely filled my heart with the right sense as to where we were as an organization. I think if there was any part of an organization that felt that that wasn't it, then we've got a much bigger problem. And therefore that's, you know, we shouldn't actually deserve to be an NHS provider. But that wasn't the case for this trust. There was a moment where I discovered on the Fulbourn site, walking from one site to the other to go and be slightly feral, I found the route to Tesco, which was quite an interesting experience, walking around the back of the site, having a quick look at some of the areas around there, and bumped into a family on the way back that were very distressed. They were walking back from Denby, and I smiled because they were very upset. There were 5 of the individuals walking back, and smiled and just sort of kept my head down. And they were really visibly upset and distressed, and I couldn't stop myself by asking, were they okay? And I had my badge on, but the proper bit of the badge wasn't showing. The lanyard was, and they obviously recognised I was a member of staff, and they'd explained to me that they just had some difficult news of a family member that was being cared for by our services. And I then said, would they want to go somewhere to sit, to have a coffee over in the resource centre, or get them a room or an office, or quite frankly, I'd have taken them to my office. And they were saying no, they didn't want to do that. But they explained a bit about their relationship with the organisation. And then I asked them if they wouldn't mind me asking the question of how was the care that their loved one was receiving. And they asked me what I did for a living. And so at that point, I told them that I was the new chief executive. And the family's response to me was something that was really heartfelt. Actually, it was, A, they were surprised I'd asked them the question. B, they were really surprised of the job that I was doing, which did worry me a little bit. So I'm just wondered, do I not look like a chief exec? So if there's anything you think I need to do differently, then please let me know. But the third, I think, was my approach to them. And they were, it upset me in a very positive way, because they were incredibly gifting of the feedback that they gave, the relationship they'd had with the clinicians on the ward. They wanted me to know about the fact that even when things were very difficult with a loved one that was experiencing a lot of neurological difficulties, that when those moments were really difficult, somebody came and asked them, do you want a cup of tea? Do you want a minute? They came and spent the time to explain what was happening. And it was just everything about an organisation in that moment there, at that 10 minutes, standing outside talking to a family, probably a very difficult period of their lives, being able to capture the spirit and the vision of an organisation in a couple of sentences made the world a very different place for me. And I think one of the things that I was very pleased about there was that that was the core essence of the organisation that we collectively in this room lead, and we try to inspire wherever we can. But when I went back to the ward to give them that feedback, the thing that really hit me quite hard was the response that came back with, thank you, but we're just doing our job. And that was something else in the right sense of humility of a team that believe that they just go to work to do their job. And actually what they'd given there was a sense of hope. They'd given a sense of connection, and given a real sense of care that went beyond the transaction of the service that they were giving to the individual we were looking after. That gave me a huge amount of hope and insight into this organisation. And I think the core essence of where we're heading is rather exciting, actually. If we look back at some of the issues that shape the organisation's behaviour now and its personality now, and all of the difficulties it's been through, the one thing we must do from that is learn from that. We mustn't dwell in that space. We mustn't be victims in that space. We must have insight, learn from that, and deploy that into a future that we deserve as an organisation, but we deserve it on behalf of the people we look after and those who work for us. There are 4,500 people going to work every day to just do their job. And right now we're on a meeting talking about some of these things. but there are hundreds, if not thousands, of our staff just about to do a shift changeover, doing the evening shift, looking after people, and we must never forget that. The bit that I think has been very eye-opening for me in terms of where we are, though, and you've seen from some of the briefs that we've sent, Eileen and I try to write to you on a Friday to sort of tell you about what we've been up to, really, and some of the things that we've been talking about, and some of the areas that we've really wanted to road test, check on a resilience level. And we've been rather unapologetically pushy in some areas where we feel that we're not doing the best for the people we look after. The future now around resetting our organizational strategy, or actually creating one that we're all proud of. One of the areas where governors, in my view, have a really active role is shaping and co-producing that with us. This is not just about a piece of paper that we stick on a shelf that's got a few objectives and nice boxes in it. This is about a signal to the organization about the fact that the future has us in the driving seat. It's a collective. This is about us inspiring what we want to see. We will always get restraints around us, whether it be political, financial, resource. It doesn't matter what they are. There will always be reasons why we can't do things, but that should never stop us from trying to achieve them. And so I think the 5 or 6 areas that we want to really work on with you is fundamentally changing our culture as an organization, making it feel like it's an outstanding place to work. If the CQC are listening to this call, I won't apologize for my statement, but the CQC are incredibly helpful, objective partners that will help us understand what really good looks like. They will give us a real benchmark as to what outstanding looks like. And some of that is in providing demonstrable evidence that we've achieved that. That's only part of the success, I think, for CPFT that we want to achieve. The second is how it feels when you come to work here, how it feels when you're a patient here, and how it feels when you seek support from us. So our culture is incredibly important, and that includes being really innovative around our learning and development. I want to make a very clear message to everybody on this call from my own value base, that one of the things that I want CPFT to be proud of and be a vanguard in is diversity and anti-racism, being really clear about the richness of diversity, bringing something completely unique. And I cannot see why we don't want to be a vanguard in that space and learn from others' cultures, others' experiences, and others' insights. I really want us to have a real strengthened values and behavioural framework, and that sometimes can be a little bit tricky because we need to be able to say when things aren't being delivered in a value base, and there is a fine line here between people believing they're not being heard, but actually it's the fact that you don't agree with them is different than not being listened to. And I think there is a real sense of us setting a series of lived values that we role model throughout the executive team, throughout the top leadership team, and then throughout the organization. And we will bump into each other on the way of that because we're humans. But the reality of it is, if our core skill set is matched to our core values, then we will make this a much better place to work. I've been really pleased to work with a very good executive team, and those execs that have joined us this evening, thank you for joining us. And I think all of them, I hope, would back me into the fact that this is a great opportunity to reset some of our collective objectives, to strengthen the executive team, be really clear on our role in terms of leading parts and all of the organisation, and setting the tone that we want to see with any member of staff at any point in our future. The next area I want to really focus on really is this strategy conversation, and strategy is something that feel very strongly about. But for us, we need a 5-year vision as to where we're heading. Now, I won't bore you with the technical elements of this, but we've got a new NHS 10-year plan that's going to land in May. Secretary of State doesn't want to rush that. Secretary of State wants to try and get that as informed as possible and as co-produced as possible. However, again, I'm conscious this is a recorded call, but I would be surprised if a lot of the things in that plan are not already in our thinking, because the move of hospital to community, the increase in our ability to use digital data and AI in a way that's safe but also is productive, and a real sense of strengthening our organization's resource allocations by living more within our means, but being a little bit more, I'll say a little bit more, quite a lot more focused on doing not only the right thing, but doing it in the right way. And that then underpins a lot of our governance conversations. So our outcomes and performance indicators is something that we'll focus on, also as a matter of priority. And for those of you that are eagle-eyed, you'll notice that there's been a stark shift in some of those performance indicators for the better, particularly around things such as appraisals and some of our performance areas around our finances. But our strategy at the moment is this 5-year vision connected to a 10-year plan. I would like us to develop a 2-year tactical plan. And the reason for using the word tactical is getting us into a better position so that we can influence some of the things that take longer to deliver. Some of those big longer term issues are working as a collective member of an ecosystem within a system to talk about things like health inequality, to really lead the way on diversity, to break down some of the traditional boundaries that providers build between themselves. The 2-year tactical position is to really tighten ourselves up so that we become highly performing. We shed that skin that probably held us back a little bit over the last 2 years, and we give a real sense of direction for the people who work for us. Ultimately, our recruitment, our medical agency, some of our areas of problematic challenges that we're facing will start to erode and get into a much better position when we start to signal how great it is to work here and what our organisation stands for. Growth and innovation is another area, I think, of development for us. Our business development agenda should always be on the basis of being able to grow into areas where we can add significant value, where we can deploy some of our strengths to improve the outcomes for people. Claire, I'm conscious you're on this call. It was great to see you the other evening with some of your councillor colleagues, where I was making a bit of a commentary about the health and wellbeing outcomes of populations and bridging that to the NHS targets. And NHS targets are traditionally quite transactional and quite productive, whereas our local authority colleagues are much more health outcome based. And one of the things I'd like to try and do is build a very strong bridge between those two, and start tackling some of the health inequality conversations that are often difficult to do on your own. I don't believe the NHS is very good at this, if I'm honest. So I think bridging that by stepping into local authorities to work with them to help citizenship-based outcomes is probably a key strategic shift for us. And then the final area, just before I sort of conclude, I'll touch on a couple of big points for you, is our relationships and working with our voluntary sector, our charitable sector, creating strategic alliances, looking at how we support them through what will be a very difficult period of austerity. So you've heard about the budget, the impact that national insurance will start to drive with some of our economic relationships. That's going to compromise and be very challenging for some entities. We're a big multi-million-pound organisation with a part to play in our local economy with social value, but we also have the ability to really reach out to our voluntary sector agency partners, because without them, we would really struggle to deliver the care that we need. So I've floated the concept with a number of our partners now around strategic alliances, building these networks, and then starting to be very creative in that space around utilisation of CPD, sharing of training, honorary contracts, and so on. And I think that's a key area for us strategically to get into. I'm just going to end on one issue, which I know was a question that you were asking of us, so thank you for asking. I think the principal question was around our finance and resources for both this year and moving into next year. It's not easy, I think, is the short and long of it. Underpinning the 2-year tactical plan is a 6-month recovery plan. So we are in the latter part of that 6-month recovery plan. Since starting in the trust, I've asked the executive to apply a different lens to some of our recovery agenda with the implementation of something called star chambers. Star chambers originated in the Spanish Inquisition. They weren't that way, but they were a concept of trying to get much more ownership by our clinical delivery units, our directorates and our clinical teams over where efficiencies can be released. But this is about us deploying a devolved way of decision making at the ground level, where the wards, the departments, our clinical teams and clinical leadership need to take responsibility and ownership for these things, because they will transform our services with our help, because they know where it's best to transform them, as long as that transformation agenda is influenced by people who use our services and with lived experience, so that we do things collectively together. So our financial position at the moment has improved against plan. So you'll see that from the board papers. It is quite complex at the moment. There are two things that we are challenging ourselves on at the moment. One is the outturn position of the trust, whether we will go against plan or whether we will start to push very strongly towards a break-even position, which is my intention. And the second is our conversations with the ICB and the national team over some of the pay awards, which you'll have heard a little bit about. That's in the midst of quite a lot of complex conversations at the moment. The good thing is that we are being asked to project our forecast without that included, meaning that there is hope that we can start working collectively together at system, region and national level to try and work that bit through. I think the final thing is to think about next year, and next year is undoubtedly going to be challenging. So what we're trying to do at the moment is to build in a two-phase of our recovery plan. One is non-recurrent to get us to a better financial position. The second is simultaneously looking to make investments where we know that we can then take a recurrent change the year after. Some of that particularly is in our relationship with other agencies. So we've reached out and we're now a BINA organisation. So BINA is the British Indian Nurses Association. They are reaching out to be part of us as a BINA friend. They will help us with our international recruitment agenda, pastoral care and some of the support. Other areas are reaching out into some of our medical recruitment areas. And two of our clinical directorates have created some very innovative middle grade doctor roles to support consultant burnout and support consultant recruitment, which has already started to take effect. So I'm very pleased about that. What we've got to be careful of is that we make sure our net position is good, but we don't do that in a short-termist way. We reinvest things and then look towards the following year as well, which I think has started to get some traction. Finally, a big thank you to our trade unions, because we've met with our trade unions and gone through all of our recovery plan to try and work with our staff and work with some of the changes that we're making. And they were incredibly productive and supportive conversations. Hence the reason why what you'll start to see is an improved financial trajectory for the trust with, and pardon the phrase, a lot more grip and control, a lot more linearity over decision making, and a very clear set of delivery plans that we'll be able to share to show you where we are going based on assurance, not reassurance. So there's a lot in there for 8 weeks, and I think there's a lot more to do over the next few years. But with your backing and having a different conversation with you, I think this will be something that we can do together. So, Chair, I'll hand back to yourself if that's okay.
Thank you so much, Steve. And you can see why I put in the chat I haven't done a drum roll to announce Steve's arrival, because it feels like he's been here for a good long while. And so, Steve, you are truly very welcome. And I know COG would want to welcome you, but we're all hugely pleased for CPFT at your appointment, which is what I should have said before I introduced you. But anyway, I usually get there in the end. I'm going to invite Andrea to come in now. Andrea.
Thanks very much, Eileen. Well, in the COG report, we did welcome Steve. And thanks very much, Steve, for being our new Chief Exec and for being here at COG. We're delighted with your appointment. I'd also like to thank my deputy, Helen, for doing so much work in the last period when I haven't been available. And I'd like to thank Sarah for the improvements to the Governor's report, which enables us to see more clearly who the governors are, what our current vacancies are, and to sort of keep a tab on where we've got to. So thank you very much, Sarah, and thank you very much, Helen, and welcome, Steve.
Thank you very much, Andrea. Ian, did you want to ask a question?
Yeah, just briefly, Steve, is there anything from your previous experience in other foundation trusts, good practice that you think you could recommend how we could do things differently if we're working with the governors and harnessing the goodwill of the governors and from the trust point of view?
Well, I think
yes,
Steve can come in, but I think that's what Andrea was referring to when we said we'd given some ideas already, Ian, around things we could do and that we were going to work on. But Steve, do you want to be brief? I'm mindful we've got Jess waiting.
Yeah, I think, Ian, thank you. That exactly was what I was going to say. I think that what we experienced before is if you're party to the internal runnings of the organisation through formal committees of the board as observers, it doesn't give you the opportunity to kick the tires, lift the bonnet, and forgive my metaphors, but it doesn't really give you the time to explore those things in detail. And therefore it also compromises you in terms of your ability to be objective and assurance. So one of the things that we're looking to do here is to do something different, where not only can we work with you in a different space, but we can really start to focus on possibly three major areas. I think the first is people and culture, the most important part of our organization. The second is finance and resource and our performance. And then the third is strategy and business, because those three things are the staple driving forces of organizations that I've experienced. And I think having you central to a lot of those conversations, bearing in mind some of those will be very commercially sensitive, but of course we're a team, is going to be much more beneficial for us to kick the tires. There is a request in return though, and the request in return is that is not us briefing you, and it shouldn't be us briefing you. That's us talking about some of the plans in order to co-produce these things, and that's really different, and gives you the opportunity to impart some of your wisdom to us, because sometimes we are not say blinded by the rest of the stuff that we have to deal with, but sometimes we don't have that same level of objectivity.
Thanks very much.
Okay, thank you. All right. If it's okay with everybody, I'm going to invite the lovely Jess Slater, who is not so new anymore. Jess, I was going to say you're the new CEO of Healthwatch for Cambridgeshire and Peterborough, but not so new anymore, to come along and just give us an outline of what Healthwatch is doing. And then there'll be an opportunity for some questions afterwards. So Jess, you're very, very welcome.
Thank you very much. I've done a brief presentation that Sarah's going to share for us, but just a quick overview of where I come from. I've been here 7 months now. It feels like 7 years, and that's a good thing. That's a good thing. That means I've firmly got my feet under the table. But one thing we do want to get a grip of is our relationship with CPFT. So it'd be good to get to know you all in the future. I like I'm a newbie, but I don't feel I have the mammoth job Steve has, because Healthwatch is quite a small organisation in comparison, whereby we only have 15 staff. However, we do have 100 volunteers, so that in itself can be quite challenging. So I'm just going to flick through, for those of you that don't know Healthwatch, I've just got a couple of slides just introducing Healthwatch, and then I'll go on to what our plans are. But yeah, feel free to ask any questions at the end. So I've just popped this together. If you can move on to the next slide, please. Right, so I've just, Healthwatch is our, well, the Healthwatch England slogan is local health and care champion, but I like to explain it to people that we speak the voice of the people, where we represent them, or we try and get as much lived experience as we possibly can. For health and social care services, people forget we do social care. They think we're predominantly health. And it's statutory services. Our statutory duties are to provide an information and signposting service, which we do, but we also have a statutory role in what we do is enter and view. It's not a CQC inspection, but we have the right to enter and view and go into any statutory service and get the patient feedback and publish a report on it. And you might have seen the recent ones that come out around the eye clinics in the last couple of months. So if we can move on to the next slide, please. Yes, so we can get feedback and look into any statutory service, and there's a few listed there: dentists, GPs, mental health services, of course, and care homes. We in the past, I think we've inspected a lot of care homes rather than clinics. Can we move on, please? Right. So at Healthwatch, we're not just, people assume that we're a complaint service and we need to get the message out there. We're not. We receive good feedback as well, and we receive just as much good feedback as well as bad feedback. So here we have a quotation around somebody that received excellent care. If we move on to the next slide, we all know what dentists are going through at the moment. So at the moment, 15% of our phone calls are around dentistry, that we get in our information and signposting service, usually that they can't get hold of one. If we can move on then. Right, so this is the important thing. So that's what Healthwatch does in a nutshell. But one of the ways we do it in Cambridgeshire and Peterborough, because every health watch is different, there are 153 health watch in England. Some counties are split, but we provide the service for Cambridgeshire and Peterborough. So we cover the ICS footprint in that respect. One of the ways we do it, we have 4 health and care forums. So they're our direct link with services and the public. So we have people from the public, and it's an open forum. So anybody can walk off the street and go to one of those forums. And there's 4 in the over the ICS footprint, and they're held bi-monthly at the moment. If we can move on, please. The other way we do it is that we are funded through adult social care through Peterborough and Cambridgeshire to hold partnership boards. And we have 5 of those and a wheelchair user forum. So older people, sensory and visual impairment, physical, learning disability and carers forum. And 50% of those meetings are attended by people with lived experience, and they are also chaired by people with lived experience. So those partnership boards provide the council as well as other partners, and we feed those partnership boards through our health and care forums as well, through to the public, and we feed back on any policy change or any service that's not going particularly well, and they're user-led. So that's one of the ways we connect to the public through those partnership boards. They are held normally quarterly. In addition, the partnership board funds the annual summit. So this year in October, we have our 3rd annual summit. It was on health inequalities, and 200 people were invited, of which 150 were in attendance. And the public are also invited, along with people from the partnership boards and our health and care forums. During that conference, I have papers on it. We did write it up. It's the first time this year that we actually wrote a paper on the health inequalities summit. Previous years, last year was on social care, and the previous year before that was on the NHS in general. There was no paper and there was no workshops. However, I decided that if we're going to pay the £10,000 to put it on, I'd like something from it. So that paper has been publicised. It's on our website, and all our partners have received it. So if you'd like to take a look at that. And the workshops were held over 4 thematics, all chosen by the public as well. And they were on older people and rural localities, young people, children and young people, ethnic minorities, and disabilities, in physical and learning disabilities. Next slide, please. So, like Steve, you come in and you look at strategy, but I was in a fortunate position when I started in May that our strategy actually comes to an end in March. So it seemed like the right opportunity to look into changing everything we do. But not everything will change. Some things have not moved on, and I can give you a sense of where we're going with that. So we've the last strategy, the priorities, we had 5 priorities, 5 years, was done just before the pandemic hit in 2020. So ours comes to an end in April, and I'm currently going through our stakeholder events that finish mid-January, where I'll be collating all the feedback, and between us as a team and with volunteers, etc., we'll be identifying 5 priorities and then putting outcome metrics against those. One thing, there's a couple of things jumping off the page, which I can tell you about in a moment, but this is what I produce for our staff here, so they know where we are. I've got another couple of visioning events that I did, but I attended the learning disability. Fantastic, the feedback I received from that stakeholder group. Next slide, please. Yes, so the common themes come in and jumping off the page is around participation groups with GPs. 51% of our phone calls are still around primary care, and it's usually GP services rather than pharmacy and dentistry is is second with 15%. So the gaps with primary care are quite significant. In the last couple of years, we were funded by the ICB to make sure every surgery, or majority surgeries had a PPG. And I think there's only 11 now left that haven't got them. But one of the things we need to do is bring those together and create the representative forums. There is a South Forum. We're going to be doing the same in the North Place. The other thing that Healthwatch has not been so great at doing is better feedback mechanisms. We're about being like 2A, a bit like you said we did. That's come out of all the groups I've been to, that we constantly survey people. We constantly pick their brains, like gold dust their opinions, and we engage people and ask them what they want. However, we're not very good at feeding back what happens to that information, and that's a common theme. And the one thing that hasn't jumped off the page, and that's because we don't have it, is a young people's voice. We do not have. We are not done a very good job of gaining young people's voices in our engagement, and that's fairly obvious in the last 6 months since I've been here. So I do want to change that. Next slide, please. There we go. That's the end of my presentation. You can stop sharing if you wish. So is there any questions? I did want to sort of not announce because it's not decided yet, but I was supposed to meet Steve last week, but we haven't met yet, but I'm hoping to meet Steve shortly. But one of the things our directors really want to do our next summit on next October is mental health. It doesn't have to be set in stone. I do have primary care on my list. I don't know which one's the easier, if I'm honest, but it has been on the page apparently for a couple of years now, and we've not tackled it. So around Healthwatch and doing the summit on it and having that bigger conversation in a conference. So I thought it'd be a good chance to raise it here. And see what you think, but obviously I'll speak to Steve about it, and if it's a possibility, maybe we could have a save the date. And
I think that's a fantastic idea. I think we'd love to see a little bit more of a spotlight in Cambridgeshire and Peterborough on mental ill health, and it's not to say that primary care would lose out there, because primary care plays a very important role in mental ill health, so there is a nice interconnectivity between the two. So let me just go to some questions you've provoked, and I'll start with Steve and then go to Ian and then to Mike.
Yeah, hi Jess. Steve Cox, one of the associate NEDs on CPFT. Great to meet you, and thanks for the presentation. Really interested in the health inequalities report, which I will take a look at. But is there anything in particular from the recommendations that you wanted to flag now to us? There may not be, but if there is, it would be great to hear a bit more about it, and I'm sure we can all go in and have a good read of it. But just flicking through it now, it looks really interesting, and thank you for sharing that with us.
Yes, I would like to flag another common theme coming out of what works well, what doesn't work well, and around the challenges around all those workshops is the joining up of services, and that's often between primary care and secondary care, and we've been asked to be a conduit between it, but I don't know how we do that at Healthwatch, but we can certainly play the patient's voice in raising that as a concern. And I know it's often brought up at ICB board meeting with our chair, but yeah, the collaboration and joining up of services, because there's so many good services as well, and quite often people just don't know they're there, and quite a lot, and pathways as well. I've since found out, since I've been here, I'm still learning about services since I've been here, that you can self-refer to some of these services. You don't need a GP referral, and this is where Healthwatch can help trusts, and we can advertise that role, and we can get that out there to patients, you know, should you need it. I mean, I appreciate waiting lists are a bit of an issue at the moment, and that's fine. But yes, that's one of the common things. And of course, is one of the things we did when we were asked to do a children and young people's workshop at a summit, it was very much noticed there weren't very young children and young people on a Wednesday when they're all at school. So that's the difficulty of that. So, and we so everybody wanted the conversation, but of course we're about people with lived experience. So that's where we've got to change our ways and how we conduct our business in that respect. I hope that makes sense. So
yeah, it does. Thank you very much.
Super helpful. And Jess, I think you are connected to Maisha, who runs our children and young people's engagement team, don't you? Yeah, you are connected.
I'm one of our directors, non-executive directors, actually sits on CPFT Young People's Board. So that's useful. Yeah.
So I would strongly recommend connecting with Maisha, who runs that board. I think she'd be super helpful to you. Right. Let me go to Ian, and then Stephen, and then Mike, and then we will move on if that's okay. Ian.
Yeah, thanks. I was actually involved with Healthwatch maybe 10 plus years ago, and I think at that time they had the statutory right to go in and enter and view and inspect health services facilities. I just wondered if that still is something that you do or not, because I remember we actually went in, I think it was to the urgent walk-in centre in Peterborough, and they had like posters up, this was in the winter time, saying, don't get sunburned, make sure you go out into the sun, with sun protection, so simple things like that, we're picking up on.
Yes, so that's what that's our enter and view service. So we can give notice to go in and view a service. We tend to spend the day there, and it's a snapshot of the day, so it's how that particular day goes. But quite often it's a visual inspection as well, and they do the dementia friendly check, 15 steps during that session, and after that we would present a report with the positives, the challenges, and any recommendations. So I think it's the first time since I've started we've actually had requests for enter and view, whereas normally it's our decision on when we're to do it, and it's usually based on we're hearing poor things about a service. So we did one on an A&E a couple of years ago, I think, and it needs doing again because I don't think any of the recommended changes have actually been done. But just recently we did all 5 eye clinics in Cambridge and Peterborough hospitals, and there was recommendations out of that, and I know, and now they've invited us to support them with that and how we're going to do that. So yeah, those sort of things, and it is simple things like directions, visuals, all the things that the patients tell us that that's all they want really, is direction, contact, good communication, and that come out nationally with Healthwatch England as well.
Thank you very much. Thank you.
It's really important. I think it is just important to clarify for everybody, and this is the old regulator in me that can't help but say it, which is that Healthwatch don't carry out inspections. The only body that inspects health and social care settings is the Care Quality Commission, but these visits are hugely helpful. Stephen, and then Mike.
Thanks very much, Eileen. Hi, Jess. This is probably more of a statement. It's actually to let one, thank you for the presentation, really helpful. Secondly, actually, thank you for attending the Mental Health, Learning Disability and Autism ABU board, because it was great you were there, and it really sort of showed a commitment from Healthwatch. And actually, when you're talking about, next year a conference around mental health, I just think of the integrated nature of the ABU and CPFT's core part in that, and it'd be great to work with you on that next year.
That's really good, and we prefer to do it in partnership, and you can't do that without CPFT. It's such a big player, but of course it involves everybody, voluntary sector, and everything. So it's probably a good way to bring that all those organisations, all that good expertise together, really, doesn't it?
Brilliant. Okay, and Jess, from Ed, you've got an excellent suggestion in there about routes to engaging with young people, so I would really suggest you follow up with Ed, who's a fount of all knowledge on certain things, which would be brilliant. Mike, do you want to come in?
Yes, hello. Thanks, Jess. I'm Mike Napton. I'm one of the non-exec directors. I was appointed in May. I've had a background in general practice in and around Cambridge for 40 years, so that's me. And I've been asked by Eileen to take on the chair of the Quality and Safety Committee, one of the subcommittees of the board. And I'm probably getting a bit boring about this, but I'm at pains to point out that that is the Quality, Safety, Patient Engagement and Carer Committee. That's where we look at those things. So I guess my question will be, how do we hear what you guys have heard from your users and people with lived experience, and is it good enough, and can we make it better? Because as I say, this is going to be a rich source of information to add to the other sorts of information we get through PALs and complaints and friends and family tests and all of that sort of stuff.
Right, so this is where, yes, this is what we haven't got with CPFT. And don't get me wrong, I'm actually in the same position as CPFT with Healthwatch was. We were missing a CEO for quite some time. So
Right.
this, some of these contacts we've had to re-establish. So we now have like a head of patient experience contact with CUH, for instance. So I have tried to arrange a meeting with Anna Chuk. I know she's really busy. She's head of patient experience at CPFT. She does attend our health and care forums actually, and she presented this week. So we're still trying to get a date in the diary, because I know that's you guys are really busy. But what we normally do is we will report any feedback, which we download off our database, and we send it to the patient. That normally starts. If you can hear my dog barking, she's just wanting to go out. So we need to establish those relationships and links. And then what we've got with the other foundations now is that we meet with them usually either once a month or quarterly, based on the need.
Terrific. So it sounds as though there's a bit of work to do in terms of making that work better, but it's useful to be sensitized to that. And I mean, obviously I talk to Anna too, and I've been to the carers board and things. So we can build on that in the new year, I think. Yes. Thank you very much.
Jess, I think we should say an enormous thank you to you for coming and being with us this evening, but also to Healthwatch for the work that you do. You've been hugely helpful to us in the last few months in many ways. I won't go into now, but hugely, hugely helpful. And I think from what you've heard, we want to work ever more closely with you and support your work just as you can support ours. So let's keep the dialogue going, because it can only help each other and the people that we serve by doing so. So thank you.
You're very welcome. And of course, I'll meet you, whoever I need to meet. Steve will meet us very soon.
Brilliant. He'll give you coffee, Jess. I can guarantee you that. I hope you like coffee. I hate the stuff. But anyway, there we go. Coffee is always available. Right. Thank you so much. I'm going to move on now to the reports from the committees, and I'm going to turn first to Pri, who is, I think, just going to also touch upon the issues around the staff workplace safety report that came to one of the last meetings of the committee. So Pri, to you.
Oh, good evening, everyone. Thank you. Right, bear with me, I'm just working off one screen. So the report that I'm providing, one, I'll take it as read, but it is, and I think we can all acknowledge there are challenges in terms of the timings of committee meetings and when papers need to be submitted. So what's presented tonight is based on the meeting that was held in September. We have had a meeting since, but in terms of timing, it's not possible to bring the papers from that to this meeting. Many of the issues are the same, but what we've raised here is, as a committee, I mean, I think I should just say, first of all, we have a lot of really positive discussions about the really good work that is done across the trust. Obviously, at a certain point, we have to raise certain issues, but we do always try and make a point about thanking staff and recognising good work where it's possible to, and raising that more broadly. One of the things that we did want to raise was we did have a concern about the vacancy rate at that point in time within Children, Young People's and Families Directorate. And more importantly, not just the vacancy rate, but the impact that has on our ability to deliver services. And I know Steve mentioned earlier about actually one of the issues challenges we have. It's not really about finances, but it's about the resource that we have available. And so as a committee, we clearly monitor these kind of results, but we are always slightly working, we're looking at backdated figures. But I know that the directorates themselves are conscious of it, and the recruitment team are very much aware of it and are trying to support as well. But it's just to reassure the governors that actually that's something that we are concerned about. We also discussed a challenge that we're having with the consultant job planning process. Some of this is process related in that the process itself has changed and is slightly more complex than it was in the past. So there is an engagement issue, which I know that our CMO a chief medical officer is working on, but also just the ability to complete it is slightly more complicated than it was. So we will monitor that, and it is brought to our committee meetings, but obviously did want to raise that. We have mentioned this a number of times. We do discuss the appraisal rate, and whilst the completion rate is important, and the last figure I was given was that we were at about 85%, but really what we discuss is about the impact that having a discussion with every member of staff has on their engagement with us as the trust, on their development, whatever that looks like, and just understanding about their well-being as well as their personal professional development. So we are monitoring that, and yes, to some degree the percentage is a blunt instrument, but it does help us just to focus in on what's important. The ICB more broadly are looking at staff retention and well-being, but that is something that we as a trust have been discussing regularly, certainly since I've been part of the trust. Also, there is going to be a change to our long service awards, which, and again, I know Steve is very conscious about making sure that we very publicly recognise the contribution that our members of staff make. So I think we do a lot already. So I think that's certainly not to do a disservice to what already exists, but we are conscious that more can be done. In terms of the assurance, the core training and the mandatory training for the role are at good levels. I mean, there is always more everybody can do, and I know that we won't lose focus on that, and certainly the trust won't. There were some concerns raised a number of times about the vacancy control panel, and we've the communications around that are certainly much better. Staff networks surrounding equity, diversity and inclusion. The exec team have taken individual responsibility for different networks and will sponsor them. So that's, I think, a real signalling to staff and people more broadly that we value the networks and the value that they bring. The wellbeing teams, as I said, have provided for a long time a really valuable support to staff, patients and our service users. And I won't steal anybody's thunder, but the learning and organisational development team have done some really, really good work producing a framework of behaviours, and that will be rolled out more broadly. Now, the one thing I wanted to mention in addition, bear with me a second, there have been some discussions about staff safety, and I'm aware that it's an unfortunate but a really hot topic. And so I think there are lots of things we already do. I think there is more that we can always do as a trust. The discussions that we've had as a committee, and certainly in some of the non-exec discussions or board discussions, are for us making sure that staff understand that their physical well-being is very important to us. We have to be sure that levels of training and understanding are there at all levels of the trust, so that people understand what needs to be in place to ensure their physical safety from carers or from more likely patients or service users. I think it's an unfortunate. I think it's inevitable that sometimes things will happen, but what's important is that we minimise the number of events that occur, and when events do occur, that we're very clear about the routes where members of staff can get support, and that's not just through line managers, but that there are lots of different services they can access internally and externally. And I think what we need to do, certainly probably as a committee, is that the People and Culture Committee just need to make sure that we are assured that as much is in place as possible and that staff understand where they get that support and help from. I think in terms of timing, I'll stop there, but ask if there's any questions. Thank you.
So Priya, I had shared with you Nora's idea about a staff safety champion, and I think you were going to follow up directly with Nora on that to just understand a bit more, because clearly we do have routes to support for staff, and there is nothing really more important than supporting a member of staff who has been injured or traumatized in any way by an incident, bearing in mind that sometimes these things can and will happen. So we just want to make sure that staff feel consistently well supported and trained to actually pick up on signs of when something may happen. So Nora, if that's okay with you, Pri and Stephen were planning to pick up just to pick your brains from your experience, and also to get some sense of what you might have seen in other places, if that's okay. But any questions for Pri before we move on? The hands. Okay, in which case, Steve, you're covering the Business and Performance Committee report this evening, and Steve Grange has kindly covered off the financial performance or position of the trust to date and the work that's been done to get us to break even, which is what we very much are endeavouring to do. But do you want to draw out the other highlights from Business and Performance?
Will do. Thanks, Eileen. And just to say, we had an extraordinary meeting of Business and Performance Committee in November to get an update on the financial recovery plan, and everything that Steve has said earlier about the Star Chambers is something that we were briefed about, and I think took some assurance from in terms of the process that we're going through. So, and we'll do again when we meet as BNP later this month. Just two or three things I was going to flag from what was a meeting of the committee in October, and you'll see from the report there's quite a number of items that were on that agenda. But looking at the priorities that were on this agenda, freedom of information was one point that we're keeping a very close eye on at BNP. I'm pleased that performance is continuing to improve, but there is still a lot more that needs to be done. The 22-23 backlog has been cleared, which is great, but there are still 5 outstanding FOIs from 23-24 that I know the team are working hard on. The response rate this year is at 70% of responses within the 20 days, which is an improvement on the 63% from last year. So the trajectory is positive. And also in the autumn, a few I think 4 or 5 weeks ago, new software has been introduced with training to help speed up and provide extra capacity to help with those responses. We'll be looking to see how that is having an impact at our next meeting of the committee, as I say, later this month. So keeping a very close watch on that, but pleased to note the progress that's being made. On performance, out of area placements and waiting lists, as you would expect, very much in our focus at BNP, and efforts that are being made to improve the patient flow. A couple of examples of work that we've heard about that I think can make a difference. For example, on the ADHD waiting list, we're working with the ICB on a proposal that we will hopefully get support for, that will bring capacity to address some of those issues, and that's something that we'll continue to press at the senior level to get support. And also on delayed discharge, so these are sort of where partners can help us in some of this as well as helping ourselves. Housing is a big obstacle to delayed or preventing discharge. So we're continuing to work through the ICB with local authorities to see what solutions we can collectively come forward with that will help us address that particular issue. The Children's Hospital, I'll just touch on that. So the board next week, I think it is, will be asked to formalise the group that we have at CPFT into a formal subcommittee, which I think is reflecting the importance of the project to ourselves, but also to the system as a whole. And some of the key issues that we'll be flagging and looking at or briefing the board on next week are really important in themselves. So electronic patient records, future clinical operational governance arrangements, the procurement process that the partnership is going through with the hospital. And really importantly, I think for the board, it's making it really clear the implications and opportunities for CPFT that are created by the process and the Children's Hospital. We want that to be very explicit, and also a clear set of timelines for decisions that we're going to be asked to make at CPFT, so that we are ready to take them briefed and comfortable with the timeline. As a good partner in the process, we want to make sure we're aware, board is aware, but also challenging, asking questions to make sure that CPFT's concerns and interests are properly looked at and tested. Those were the few updates I wanted to add, Eileen. Finance, clearly we've covered already, which is a big part of BNP's work as well, but I'll leave it there. Thank you.
All right. Thank you so much, Steve. Ian, did you want to come in?
Well, sorry, it was just about on the finance, actually. We didn't get a detailed income and expenditure summary account in the papers this time, is that right? Normally we get like what's equivalent of a profit and loss account, you know, year-to-date figures included with the governor's papers. It didn't seem to be happening this time.
Well, I'm sure it was in the board papers, Ian, so we'll see if we can dig it out for you.
Right. No, just normally I think they come with the, you know, the COG papers as well. You get the, you know, financial reports saying, you know, year-to-date figures or whatever, you know, income, expenditure, and broken down and so on.
Right. Well, we can send you the board paper that's relevant if Sarah can pick that up.
Yeah, thanks.
Okay. Anybody else any questions for Steve at all? Steve, did you want to come in?
Yeah, thanks, Eileen. Not a question, just to support Steve, really. I think thank you to the committee for being our scrutiny, really, eyes and ears over some of the plans that are developing now. And it's really helpful, I think, Steve, for your good self and other members of the committee to be assured that the plans that we're putting in place are both things that we need to do to transform services, but also those things that are going to not have unintended consequences on quality and safety. It's really important that we nail that bit down. The forecast for us, I think, as we get into this next stage on our recovery position is going to be inclusive of the money as well as some of the big actions that Steve's mentioned, Chair. And I think one of those particularly is the out-of-county placement. So as of today, I say the words we only have because one is too many, but we only have 8 of our clients out of county that are inappropriately referred out of county, because I'm really pleased to say that the work on Mulberry 3 has been concluded and the ward is fully opened, fully staffed, and is managing now repatriation. That's really important because that's a month ahead of schedule in terms of the space that they're in. And our OPAC services have 0 out of county as of today, which is fantastic. There is a space, though, where we need to work with our ICB partners for areas that we don't have services, where patients do have to travel further. And that then needs to start talking about our business development space, where we have the expertise to look after individuals, but we don't have a commission service to manage that properly. So at this point, one of the things that we'll be doing with our out of county is looking at our flow through our inpatient facilities, but then also working with ICBs on trying to look where we can then reinvest to make sure that people don't have to travel. Steve, there's one other thing, if you don't mind, you mentioned it around the performance aspects of ADHD. Those services are incredibly compromised across the country, and I think there's a heightened level of activity around diagnostics to do with both autism and ADHD. And it's really important for Council of Governors to understand that the service that we currently provide is being outstripped from a demand point of view up to 10-fold in terms of the requests on that service. So this is a piece of work that we're doing with our commissioning colleagues to help them understand the contract that we have and the service that we provide very much needs to be rebased and very much needs to be invested in for us to be able to do a good job here. Otherwise, people are waiting longer. But we need to do that collectively with our partners and not sort of create problems. But it is something that we are very sighted on. And I think it's something that we need to probably keep bringing back here to give you an update on.
No, absolutely. And I was in a meeting this morning where somebody from NHS England, who's their new lead on mental health and neurodiversity, was saying one of the things he would recommend is that we start talking about the waiting lists. The waiting list for an ADHD appointment is in many instances as important as waiting to have a scan on your hip or to have a cataract looked at. but somehow it's treated as a second order issue. So Adrian's advice is that we actually talk about these being elective appointments, and some of them acute, and that we should talk about waiting lists in that way, which I thought was sound advice, to be honest. Thank you both very much for that. If the committee's content, I'm going to ask that we move on to quality, safety and experience. Mike, if you could lead us through that, that would be fantastic.
Thanks, Eileen. I'm speaking to a report that Karen Daber produced, covering off the 2 quality and safety meetings that we had in September and October. The next one is on the 11th of December. So thanks to Karen. So the first thing to say is that there have been some changes in the committee, and Karen Daber is now deputy chair of the organisation, and as such has stepped down as chair of Quality and Safety Committee, and I've been invited to take on that role, which will start on the 11th of December. So kind of appropriate that I'm talking to this today. We've also reviewed our terms of reference and cycle of business. Karen will step down from the committee, so I'm absolutely delighted that Ed Bullmore is going to join us, who will add considerably to our thinking with regards to quality and safety, with his clinical school and research interests. So that's absolutely great. And also just to call out Helen as well, who's the governor rep on the committee, who is very welcome and very helpful having her there. So that's the changes in the committee. So just some of the things that occurred to me, that you've got the report there, but out of area placements has already been touched on. This is clearly a performance issue, it's a financial issue, but it is also a quality and safety issue. There was a very, very good report which I would commend to you from the Health Service Safety Investigation Body, which was an interesting report looking at the harm that occurs to people who find themselves looked after as an out of area placement. And it was an interesting report because there's a caveat at the beginning of it which says you may find reading this report distressing. And I don't often see that in reports. So the HSSIB report, I think, is worth a look at, which is, it's not that we don't know about these sort of safety issues, but it just increases our resolve to get out of area placements down to 0. And Steve's already mentioned that the Mulberry wards are open, which will contribute to that, but managing delayed discharges is another aspect to how we're going to look after our own patients in our own wards. There's a new service for eating disorders. You may know the Phoenix closed some time ago, and the Beacon is now an outpatient-based service for eating disorders. Delighted that started, and we've asked for a review in March, April time to see how that's going in terms of quality and safety. Great progress with mortality and learning from deaths. And there's also Kathy Walsh, the medical director, set up a learning from suicides oversight group as well. So I think we can be assured that that is given the appropriate attention it needs. We are concerned though about waiting lists already being talked about. So you've got ADHD and learning disability, autism, and actually speech and language therapy. So it's not just mental health waiting lists, it's community services waiting lists as well, are too long. And so we are doing our best to think about the quality and safety issues relating to those people who have been referred but haven't been seen by CPFT, and can we enable there isn't really a methodology, as I understand it, for looking at harm reduction on waiting lists, but we can think about how we can support people on the waiting list while they're waiting for their appointment. I know Venkat Reddy is doing some work on that, and Steve's already, Cox alluded to talking to the ICB about commissioning services. And there's also another issue, which is not a waiting list, but the medical advisory group had a very good meeting on the provision of clozapine clinics across the county, and at the moment there's a mismatch between those that are eligible for clozapine treatment and those who get it. And at the moment, I think the figure was 25% of those who were eligible are actually getting clozapine treatment. But there was a fantastic presentation, and Steve Grange was there to see that, which was about setting up virtual clinics, virtual wards, as a way of increasing our capacity and ability to provide clozapine appropriately to patients. So that's exciting because it's addressing an absence of care treatment, but also it's an innovative way of doing that. And then just finally, quickly, you posed some questions, Andrea, I think in advance of the meeting, and so I'm going to try and answer them, but if I get it wrong, I'm sorry. So Helen very kindly said that there's optimism that the subcommittee will be improving with, I don't know about the change of chair, but input from Rachel, and we're sort of thinking about it. We'll see how the chair does. You've already talked about the report is too process driven and governors don't therefore get the assurance. Do you know, that's something that I think about a lot as well as a chair, as a NED. And I had a very good discussion, interestingly, with colleagues from the ICB this morning. So that's Dorothy Gregson, who chairs the quality committee for the ICB, and Carol Anderson, the chief nurse, who also have the same issues about how do you properly assure yourself that the service. So we do it reasonably well, but I think there's a lot more we could think about how we do that better. So I don't know if that's an answer to the question, but it's a sort of empathetic feeling that we have the same questions in mind. Pre's already talked about assaults on staff, and there's figures in that report: 3,141 assaults on staff in the first quarter of this year, from January 22 to May 24. So it's happening. Mike Seaman brought a report about that, and he's going to come back with some actions which I think can be bottled up into what are we going to do to support staff, but what can we do to prevent these happening in the first place. And actually some of these assaults are perpetrated by people who are very sick or have dementia, and can we create an environment where they don't get distressed and don't then behave in a way which puts staff at risk. So there's different ways of looking at that. So I think we're onto that. Safer staffing, you will correct me if I'm wrong, but I think that is no longer a quality committee responsibility to look at safer staffing, and it's going to come to people and culture. And similarly, you've touched on safety champions. Finally, CQC updates. There's a lot of work going on regards CQC in preparation for the well-led investigation in February, but we've also got a number of unannounced visits to working age adult mental health inpatients, I think forensic services, some community services, and those reports go through a process through a compliance committee, which basically checks the findings, takes those findings, turns them into an action plan. Those action plans then get reported back to the Quality and Safety Committee. So whilst it can take too long in my mind, but it's happening, and we look at that on a regular basis. So somebody said CQC update please. It was due in October. It's not on our agenda, just to be assured that we have this on our Q&S agenda.
And there is going to be a development session in January around the CQC, so that
that's right, 14th. Yeah. So
14th
that's
of January.
Yeah, development session on that. So anyway, there we go. I've talked too much.
No, thank you so much, Mike. All good value. Helen, did you want to come in?
Thanks, Eileen, and thanks, Mike. Yes, I just wanted to clarify, thanks for referring to me and Andrea's notes. I just wanted to clarify from that summary that the feedback to the governors was that Karen, as the chair beforehand, had increased the number of meetings and reviewed quite thoroughly the level of assurance and introduced a new scheme. So my optimism was that we are on the right track, and in no way a reflection of Karen, if indeed anybody could have taken it that way. Just from hearing the summary.
Absolutely. I mean, it's about getting better, not about criticising what went on in the past. Yeah. And that's what we're trying to do. And going to bi-monthly, I think will be better, make better use of people's time. There is an issue about timing of data. So what you want to do is to make sure that you don't have a meeting every 2 months, which means you're looking at old data. So we're thinking about that. And the other is pace and change in terms of how action plans have progressed. If you're not looking at them every month, does that mean that there'll be some inertia there? I don't think so, actually. I think it's better to have 8 weeks between meetings, and at that point you can actually see meaningful progress, whereas having them every month, it can get a bit repetitive. So I'm hoping that the decision to go bi-monthly is the right one. We'll see. Okay,
I just saw Steve Grange wince at the mention of inertia. It's not a word he tolerates, I think, so we have no inertia. Pri, did you want to come in?
Yeah, just a really small point. Helen, completely agree with you. I suppose I just wanted to point out that also when Karen was chairing for the majority of the time, it also included the people element as well. So the agendas were absolutely enormous, and it was never possible to cover everything we needed to as a committee with the time we had available. So which is one of the reasons that we went to monthly. But I think now splitting it out over 2 committees makes it more possible. And as Mike said, the timing of the data works better as well. Thanks.
That is brilliant. Thank you so much. Could we then go to Jackie, who's going to update us on Head to Toes Charitable Funds Committee report?
Thank you, Eileen, and good evening, everybody. Firstly, chairing or co-chairing the charity committee is always a delight, and Ed and I do that jointly. And I was just listening to some of the themes that were coming through tonight, and one of the things that we experienced at the charity meeting is a very energetic and colourful update from Hannah, who is the head of our charity. And a recent newsletter went out, I think it was a couple of weeks ago, onto our website. And this is my own ignorance, so I apologise that you may not have access to that. But if it's useful for you to see the sort of breadth and depth that the charity operates and all the good work that they are doing across the trust, I think we should probably find a way of being able to share that newsletter with governors as well. And it links very nicely to Andrea's question around the charitable funds. Well, it's a suggestion really, and it's very welcome in terms of the connection between the charity and some of the events that governors go to. And is there a link there to work in a more of a partnership way? And obviously, Andrea, I think the answer is yes. We probably just need to find a way of doing that. And I was just looking to see whether Sharon was on the call, who is our governor that observes and participates in the committee meeting. Maybe I can connect Hannah and Sharon to start forming that relationship, because I think that would be really, really helpful. We have also, through Hannah, really progressed the partnership working between Hannah Took and the volunteers and the charity as well. So that's a growing theme in terms of the charity. At our last meeting, we also confirmed a revision of our terms of reference, so similar to Mike, and those terms of reference are approved now by that committee. And as part of that, we changed our name, a small thing, but it actually meant a lot, because we call ourselves the Charity Fund Management Committee, but actually we are changing it to the Head and Toe Charity Committee, so it does what it says on the tin, and people recognise that committee for the work it does. And that's just waiting for approval through the audit committee and a tick from Caroline to make sure that there's consistency with our terms of reference. We spent quite a bit of time talking about balancing the small stuff that makes and has a huge impact on colleagues and service users versus the strategy and the sort of more significant initiatives, especially ones around green wards. And as a result of a very fruitful conversation, we have rested on the fact that we need to really look at the direction that the strategy is going in its entirety. And Chris, who is the Director of Communications and Engagement and Charity, and Hannah but have recently had a conversation with our chief exec, Steve Grange, and we are shaping up an approach of how to do that review. And I think Steve Grange, at the last time we touched on this, is proposing a business case with some options as well, which really talks about how we sustain this charity for the longer term. I'll stop there, but thank you very much.
Thank you, Jackie, and my apologies. My my Wi-Fi fell over in the midst of Jackie's talking, so I'm sure it was all marvellous. Let me bring in Steve, and then Jackie's co-chair Ed on this.
Thanks, Eileen, and Jackie, thank you for raising that. And my apologies. My Wi-Fi is doing something similar, so I'm using a combination of my mobile phone and this, and then something's just landed on the roof because it's in the middle of a storm. So if I suddenly disappear, I'm off to Kansas. So my apologies. It's a really good point that Jackie raises, and I think it's something that we will bring back here with your agreement. When we start to reshape both our head-to-toe charity and heart and soul concepts, is we need to make sure that both of those are sustainable into the future, because they are very much a signal of this organisation's social responsibilities and the ability for us to influence our communities in a different way than health is designed to. So I think the bit that I've met with Hannah and the team, met with Chris, and what we're talking about is the development of and it's a dirty word in charitable sense, but I apologise for this, but a business plan, talking about how we can utilise some of the areas where I think Head to Toe can start to develop itself more with the Charities Commission, with sources of funding that we can't normally access as an NHS provider, and bring that back into our strategy. So just to assure non-exec members and governors that will be done in the next couple of months as we start to shape this up, ready for next year when we start to enter the new commissioning rounds.
Thank you so much, Steve. And apologies, my Wi-Fi has now dropped twice since I last said it, so it dropped, so I will keep persisting, but if I'm gone, I probably will be gone. Ed, did you want to come in?
Yeah, thank you, Eileen. Yeah, so I think Jackie summarised the situation very well and clearly from the co-chair point of view. Just to pick up on the going greenwards, or the sort of interest we have long term in doing something to improve the external space, garden space on CPFT estate, which is highly valued by staff and service users. And it's been really great to see the sort of engagement of particularly the allied health professionals, I think, occupational therapists and others around the trust. Turns out there's already quite a lot going on there, which we can build on, we hope. So that is great. And also just to reflect that there has definitely been a shift in the kind of, the sort of strategic thinking about the charity since Steve joined, and that is really very welcome. But it's my main duty is a really pleasant one, which is to just reflect that the team itself, small core team, is still very active, and of course it is the festive season, and next Thursday, 12th of December week today, 11:30 to 2:30. I hope governors are already aware, but if you're not, please feel invited to a event at the Resource Centre, Fulbourn, which will, is a bit of a sort of head-to-toe showcase for the season. And Eileen and Steve agreed to relocate the board meeting to Fulbourn on Thursday, so we will be popping in at some point in proceedings. It would be great to meet up then. And very finally, Eileen would, I'm sure, think I was a bit remiss if I didn't draw your attention to the festive raffle that Head to Toe is currently running. I've popped the link in the chat, but if you just Google on Head Toe raffle, CPFT Head Toe raffle will get you their top link if you don't want to bother with the URL. But anyway, I hope to see some of you anyway next week at the festive event.
That's brilliant, Ed. I had been going to mention the raffle if you hadn't done so. I'm also going to ask Sarah to put it into the weekly note tomorrow to make sure that there is no escape for any of us. It's such a good cause, and the prizes are great as well, including a very special hamper donated by the board members this year. Then last but not least, Brian, can we go to you for the Audit and Assurance Committee report?
Yes, actually, I'll put something in as well, just and for head to toe, if anyone's around the Portland Arms on Friday night next week, 13th, Cambridge's favourite party band, The Eye, is playing a gig, and all proceeds are going to head to toe. So, anyone's welcome to that if you like a good night of loud music, a bit of R&B. So anyway, that's my plug done. My wife sings in the band. I'm sometimes the roadie. Moving on to the last report. This is the same report really that we had for the public board last week, and I'm happy to say that there are no matters of escalation or discussion that need to be brought to any attention tonight. We're in the sort of the quiet period with regard to external audit at the moment. That really kicks off with the sort of a planning session at our meeting in January. So really the focus is more on internal audits at this stage. We're making good progress in that area. One thing that is being undertaken at the moment, which will actually be helpful to feed into the well-led review, is that RSM are having a look at their governance processes, numbers of meetings and so on. And I think, well, without giving away too many secrets, the expectation is they'll say we have too many meetings and too many people involved in too many meetings. So I think that's probably going to come as a shock to no one, but that'll formally be picked up I'm hoping it'll be formally picked up in our January meeting, subject to the various bits of process being dealt with before that. The other thing I'm really pleased with is that all the outstanding management actions are being really taken seriously. And it was very good to see the chief pharmacist at our last meeting. We've had a medicines management audit. She came along to really sort of step up to and she's made good progress in the recommendations, obviously. But I take it as a very positive thing that people who aren't directly related to the finance community, A, are audited, and B, are happy to be subject to audit, internal audits. And I think that's a really good message for the organisation, and I certainly want to think it plays very well. As I'm saying, our next meeting's in middle of January. It's about the planning. The planning for the audit. One thing, I spoke to Lauren a couple of days ago, and I know Steve's aware of this, but the timing for the submission of the annual report is going to be earlier this year than it has been in previous years. So it used to be the numbers had to be supplied by about the 25th of April. Now the full annual report is going to have to be done there. So I know Steve's on top of that one, and Lauren is too, but there's going to need to be quite a lot of coordination around getting that done earlier than before. So that's a real planning exercise to be done, and I think that it's a very major task. So resourcing could be a challenge on that. The only other good thing I think is that it was pretty difficult the last couple of year ends because of valuation of buildings and PFI contracts, largely because of valuers who didn't necessarily step up to the mark or weren't able to provide the audit evidence that we needed. The good thing is that this year, so the March year end that is coming up, will be the first year in 4 that we aren't going to have a full formal valuation of our buildings, because we're just able to do a desktop review carrying forward what we had from last year. And that's probably, in terms of timetable, is a fairly substantial de-risk for us, which I think is real positive. And as things stand, having gone through the agenda with the sort of typical what could be a year-end issue list with Lauren the other day, it's the usual topics, things like deferred income, accruals, those sort of things which come up every year are going to be the topics. There are no new major issues that we're aware of at this stage, or she's aware of at this stage. So I fingers crossed that process towards the end of the year looking forward will be more positive. So sorry, I said all of that. I was taking my original report as read, obviously. I didn't say that at the start.
No, that's brilliant. Brilliant, Brian. And the thought of you as a roadie is massively entertaining me at the moment.
I've done it all. My AC/DC t-shirt on.
Goodness, you'll be leading the singing, I'm sure, because there is going to be singing next Thursday as well at Fulbourn. Any questions at all for Brian? No? Fantastic. I wasn't notified of any other business, but has any other business occurred to anybody whilst we've been chatting. I did put a question in the chat, but it's a little while ago, which is Steve and I set aside time every Friday to sit down and write to you, to give you a flavour of what's been going on, with special mention to Nora, who regularly writes to say she's enjoyed it or has a question about something. That's fantastic. We don't get a lot of feedback. So I think it's important to check whether the note is hitting the spot for you in terms of giving you a flavour of what's going on, because it can feel like it's going out into a little bit of a vacuum, to be honest. So if you do have any questions that come from it, please let us know. If you don't find it helpful anymore, please also let us know, and we'll divert the time to doing something else. So thank you for that. Thank you all for your patience this evening. It's been a really enjoyable session. So do look after yourselves, and we'll see you all again soon. Hopefully some of you in Fulbourn next week. If we don't see some of you before Christmas, have a fantastic break, lovely new year, and it's going to be a good one for CPFT. All right, take care everyone. Bye.
Thank you all.
Happy
Bye.
holidays.
Thanks.
Thank you.
Bye, thanks.
Bye.
Goodbye.